So thank you. I want to thank the organizing committee for their perfect organization, scientific and social. I'm very happy to be here. I'm very honored to have been invited, and I'm also happy to have the opportunity to share with you this concept mapping about epileptic syndromes. And I hope it will help you to find your way in this complex landscape. Concept mapping is a way to represent different relationships between concepts, between ideas. It's more and more used in medicine to teach and to approach this relationship between symptoms and diseases. And to have this graphical representation, it can provide you this global approach. And it's also a mapper, so it's like trying to find where you are in a city or where you are in a country. And for those who are like I am, a more visual learner, having a graphic representation can help you memorize complex knowledge. And knowledge about epilepsy is complex. So I hope I will help, but it's still complex. It's complex because epilepsy is a complex disease, or I should say epilepsies are complex diseases, because you have different diseases varying according to age, and epilepsies in adults are not exactly the same as epilepsies in children. You all know, I think, this bimodal incidence curve of epilepsies with high incidence, new cases during childhood, quite a low incidence during adulthood, and then incidence going up during in the elderly, with in adults most what we called remote symptomatic epilepsies, because it's associated to strokes, tumor, brain injury, infections, and epilepsy that are mostly focal epilepsies. So for some neurologists, epilepsy is sometimes more like a symptom or like a comorbidity to another neurological disease, and not always like a disease by itself. It's different in children. In children, you also have this remote symptomatic, as called before, remote symptomatic epilepsy, but you also have these genetic diseases, and you also have more generalized epilepsies than in adults, who you have more focal epilepsies. So in children, I think epilepsies are a group of diseases, many different diseases, and you have this need for classification. And for those who were yesterday in the epilepsy session, you already have seen this schema that is being presented by Professor Somerville of a new 2022 ILE classification, and the way to classify syndrome. So the first thing to classify an epileptic syndrome is first to make sure it's epilepsy, because you also always have this differential diagnosis with non-epileptic phenomenon. And then you need to identify the seizure type. Oh, I'm trying to find the seizure type, then the epilepsy type, to go to the epileptic syndrome. So identifying seizure type has been completely changed, I think, last 10 to 20 years, because you have home video. And parents, the thing you have to say, just film them. So it can be easy sometimes for, I think you all recognize the type of seizure. Spasm. So you have a type of seizure, and the parent, this parent came with a video saying, okay, my daughter is doing that for weeks now. Do you think it's normal? Not really. So you have a seizure type, and because it's a young girl, she was 1 year or something at that time, you can go quite directly to the epileptic syndrome. Okay, so the epileptic syndrome, which is the new, you already seen this graphic yesterday too. The epileptic syndrome is here. Oops. Okay. The epileptic syndrome is no longer West syndrome. Sorry, they changed everything. So now it's International Special Station. No, it's infantile spasm syndrome. Okay, it's ESS. Okay. So ESS is here. It's one of more than 30 syndromes that are characterized by the age of onset. Sorry. Age of onset here. The epilepsy type, that would be focal, generalized, or this epilepsy with very important cognitive comorbidities. And then you have a list of syndrome. But to recognize a syndrome, you need to know it before. I think you all recognize West syndrome, spasm, because you already seen spasm, infant with spasm, that is the most frequent syndrome in infants. So how can you identify a syndrome? You need to know its characteristics, and the characteristics are the age, the seizure type, the EEG, the development, and the neurological examination. So if you know the age, if you know the seizure type, if you have the EEG, and the EEG is crucial in epileptic syndrome, you have the neurological examination and the development, and you can recognize a bridge in Da Nang. Okay. But if you are looking for a bridge in Da Nang, you may end up with that bridge. That is also a bridge that is close to Da Nang, but is not in Da Nang. And it's not exactly the same bridge. So if you want to talk about a syndrome and differential diagnosis, you need to know the frontier, the limit. You need to have a clear idea of what you are looking for. Okay? And this map will help you to have a global approach. Don't take the photo, you will later the photos. This map will give you a global approach of the different syndromes. Okay, and that will help you. It's like a bridge. Oh, I've been in Da Nang, I saw a bridge. Okay, which one? So I will give you two examples. This is a young girl, 7 years, normal schooling, no medical history, and the parents just say she has some loss of contact since few weeks, few months, we don't know exactly. Oh, sorry, I need to. No. Oops. Okay, so you need a video EEG. So she's doing the hyperpia. So the EEG in France is 15 millimeter by second. So it's compressed for you maybe. So she stopped blowing. You have this EEG discharge and she stopped blowing. So you have a diagnosis, the seizure type, absence. This is another case. She's also 8 years, quite the same age. The parents also report loss of contact, but this girl has delayed speech, mild intellectual disability before the loss of context were reported. So the EEG is very high amplitude. You know, we are 800 microvolt per centimeter here. Okay, so we had also for this, she's also stopping blowing, you have this very high amplitude, very prolonged discharge. Okay. She has some automatism. Okay, and then she's resuming her activity. So when we go back to the map, we are somewhere here. You know, between 2 years and 10 years, in the generalized part, somewhere here. But somewhere here, you have quite a lot of syndrome. Okay, so if now you have to go to the detailed syndrome description you have in this very useful new papers about the classification, where you can find again seizure type, EEG, age of onset, development, neurological examen, comorbidities, imaging, etc. Okay, so when you go there for this girl, she has normal schooling, she has typical absences, normal development. You will, she has a mandatory criteria. I have to precise, we didn't talk together before with Professor Somerville, who showed the same example yesterday, but okay, so sorry. Okay, so she has typical absences. She has a good EEG with free Hertz paroxysms, and she has no alerts, so you can make the diagnosis of childhood absence epilepsy. That is here. And if you do that, you know you don't need an MRI, and you have to avoid carbamazepine and try wide spectrum anticonvulsive drugs. But for this girl, when you go back to the detailed characteristics, she has some alerts. She has a mild intellectual disability. So you can say, oh, okay, maybe it's not very typical absence epilepsy. Maybe I should treat her like a childhood absence epilepsy, but in case of pharmacoresistance, you need to go further. Okay, you need to beware. Is it, you need to make sure she has no other type of seizure, because, for example, you need to make sure she has no tonic seizures, sometimes at night, but you also need to think about some specific, one specific disease, and do a lumbar puncture. Yeah. To make sure it's not a glutathione transporter deficiency. Okay, that could, in which you could have mild intellectual disability and atypical absences, and you need a specific treatment that is ketogenic diet. Okay, and it will be pharmacoresistant. So the syndromic approach is really important because it will just help you to decide, do I need more examination? Do I need more exam? Do I have specific treatment to do? So this is quite the end for me. Now, if you have a paper, I can propose you to make on your paper these 3 concentric circles. Okay, that represent the age of onset. So you can you can draw the first one is before 3 months. You can make 1 month if you want to stick with the very specific neonatal forms. The second one is 2 years. So this is neonatal, this is infancy, and then the third one is 10 years, this is childhood. And after 10 years, it's adolescence and then adulthood. Okay, so you can first do these 3 circles. Then you can draw an arrow from the right for me and to the left between generalized and focal. Okay, epilepsy type. And another arrow, vertical one, from the less severe to more severe. Okay. Before 2022, we had here idiopathic. Okay, and idiopathic, I liked idiopathic. I don't know why they just remove idiopathic, because idiopathic means it's a disease by itself. Okay, so here we had idiopathic, and it means that in this area you have the main problem will be seizures. You won't have big problems apart pharmacoresistant. You may have some comorbidities, but not real problem. That is very different from this region here. You will have very more or less comorbidities. So you can define 4 areas. In this one, you have the now called self-limited epilepsies that are focal and previously idiopathic. Now we can say less severe. There are specific epileptic syndrome. To talk about self-limited epilepsy, you need to have all the criteria: the age, the seizure type, and the EEG. Okay, you cannot have self-limited epilepsy because you had a few focal seizures and then nothing, and a normal EEG. This is focal seizure. This is not self-limited epilepsy. Okay, this is really important. Here you have, I put the genetic, but it's idiopathic, the saved idiopathic generalized epilepsies. Okay. In this area, it's a district you should not go. Okay. You have all these developmental epileptic encephalopathies and this progressive, with this epilepsy with progressive neurological deterioration. And in this one, with most generalized, and in this one, this area, you have all the focal epilepsies. Okay? So I have still 5 minutes. You have 1 minute to put 5 syndromes in this map. Go. In your map. Go. I helped you. So I'm sure you know the absence, childhood absence, and juvenile absence epilepsies. I don't see you drawing now. Okay? Infantile spasm syndrome. Think about where you will put them. Okay? The Lennox-Gastaut. Okay? And the selects. I was not in the ELA classification. I don't know why maybe you can help with why they call that. So the new benign epilepsy with central temporal spikes is now selects. Okay. Yes. Voilà, selects. And so try to put it somewhere. And the focal epilepsy. So I will help you because they change all the abbreviation too. So you have the selects here in the focal self-limited epilepsy. They were just the CELEAS, autonomic features. It's as soon as you can say Panayotopoulos, you change. You can forget it. Now it's CELEAS. Okay. And the Gastaut is now COV, childhood onset visual epilepsy. Okay. And this one is the photosensitive occipital lobe epilepsy. Okay, now Gibbons is the other side. Gibbons is not focal, is okay. So here you have 4 idiopathic, generalized idiopathic epilepsies, absence, juvenile, and with a tonico-clonic seizure alone. Here you have all the focal. So adult neurologists, they are just mainly here with focal epilepsies. But you have the temporal lobe epilepsies, you have epilepsy with auditory features. This is a sleep hypermotor epilepsy. So this is the one with the focal various foci. This is the area where you should not go with the epilepsies with a lot of cognitive comorbidities. Okay, so we had the international special station. No, sorry, it's just no infantile spasm syndrome. Okay, the Dravet. So Charlotte Dravet kept a name. You have the Lennox-Gastaut syndrome here. Hermann Dose lost, so it's myoclonic absence, myoclonic atonic epilepsy. And then you have the Gibbons, it's with high-line myoclonia. And you have also here a list of etiology-specific epilepsies, in which you have Sturge-Weber, you have the De Vivo, you have and all those new genetically determined epilepsies. Okay, so I hope you had some syndrome put in this map. The idea is it gives you this global approach to trying to find in which area you are, because these syndromes, you cannot classify each child at the beginning in one syndrome, but you can say, okay, I don't have all the criteria, but maybe there is some generalized seizure with some deterioration. Maybe I'm here, and I should go further in the examination or of the exam I do. Okay, so, and you have also you cannot classify every child at the end. So in conclusion, it's complex because it's complex. Okay, try to make it a little bit more simple, but it's not so easy. You have many different syndromes because it's different diseases. You have different signs and symptoms, you have different clinical examination, you have different diagnosis workup, you have different treatment. Okay, so epilepsies is a group of disease, and you have to know the one you have to treat before giving new or old drugs that works the same. Okay, and you need to have this global overview. So this schema was published in I have to stop, if I can. In Neurophysiology Clinic, this is a French Neurological journal, and you have this map, and you have also all the abbreviation. Thank you for your attention.